Today we will discuss unexplained infertility. I'm sorry, there is a lot of background noise is coming because some religious program is going on. The India is a country of 33,000 gods and multiple major religion. So any one activity or all probably all of the activity of all the religions are going on some or other day. You can't help it. The diagnosis of unexplained infertility encompasses an important subset of couple seeking a treatment for infertility. After the evaluation of ovulatory function, tubal patency, semen analysis, and good normal transvaginal sonography, no etiology is identified in 10 to 30% of the couple seeking the treatment for infertility. This group comprises or labeled as unexplained infertility. The unexplained infertility is perhaps the best example of subfertility. This nomenclature is significant in that some couples will conceive without any intervention with just expectant treatment. In one randomized trial of 253 patients with unexplained infertility, a 27% ongoing pregnancy rate was observed in expectant management group and others observed 13% spontaneous pregnancy rate in a group of patients who were awaiting the IVF treatment. So this study itself signifies that unexplained infertility is a wrong name. It should be labeled as unexplained subfertility, where really there is a bright chance of conceiving spontaneously. If patient doesn't conceive spontaneously or with the expectant treatment, our strategy of treating such type of patient should be a super ovulation, which induces the development of more than one follicle per cycle, either combined with time intercourse or IUI. Because why IUI is commonly incorporated in the treatment of unexplained infertility? Because there are many subtle reason, fertilization incapabilities of the sperm, or maybe some penetration problem, some reaction with the zona pellucida. Sperm may be facing a lot of difficulties, and which can be difficult to investigate. So this subset of the patients of unexplained infertility, if we provide one extra egg or maybe some good extra quantity of good quality sperms, then the results can be improvised. The possible way of management would be either expectant treatment or clomiphene citrate with time intercourse or clomiphene citrate with IUI, aromatase inhibitor with time intercourse, aromatase inhibitor with IUI, gonadotropin with expectant treatment, gonadotropin with time intercourse, gonadotropin with IUI, and directly going to IVF. In older studies, the clomiphene citrate with time intercourse was found more effective than expectant management, although a larger, more recent trial found no benefit of clomiphene citrate with time intercourse versus expectant treatment. But when the expectant management was compared either with CCIUI or gonadotropin IUI, Both were found either more effective than just expectant treatment. As per the ASRM committee opinion, the CC with intercourse for unexplained infertility should be discouraged. However, they suggested the further studies needed to assess the effectiveness of empirical CC for unexplained infertility. But when used in combination with IUI, CC seems to be beneficial compared to expectant management. When clomiphene citrate and letrozole, of course, letrozole is banned in India, along with IUI was compared, the letrozole with IUI was superior in one study. The larger, more recent Diamond trial showed a high ongoing pregnancy rate and live birth rate with CC, although the difference was not statistically significant. There are two studies that examine the letrozole with IUI versus gonadotropin with IUI, and they showed that these interventions were equally effective. The Diamond demonstrated that the gonadotropin were significantly more effective than either letrozole or clomiphene, especially in older group of patients of unexplained infertility. On the basis of currently available literature, the expectant management may be comparable to a treatment with CC and time intercourse or IUI in patients with unexplained infertility. The clomiphene may be more effective than letrozole. The treatment with the gonadotropin seems to be more effective than either oral agent, although its attendant risk of multiple gestation is an obvious disadvantage, and that should limit the utilization despite its cost and widespread utilization. IVF was no more effective than gonadotropin with IUI, but it accelerates the time to clinical pregnancy. The number of the IUI cycles should be restricted to not more than 3 because the unexplained infertility is an unfavorable factor on the probability to obtain a pregnancy in an IUI cycle. On the one hand, this diagnosis comprises too wide a range of infertile population, such as undiagnosed cases of mild endometriosis, and lacks identification homogeny. The IUI is statistically superior to no treatment at all, but the effect is minimal in couple with unexplained infertility. On the other hand, a substantial number of the patients with unexplained infertility may have a small chance of achieving pregnancy through IUI, possibly linked to a fertilization disorder as observed in further IVF treatment. For this reason, in case of unexplained infertility, some authors advise performing ICSI after 3 IUI failure. When you are giving oral agents in unexplained infertility for IUI cycle, the thin endometrium is more common among the women undergoing either letrozole with IUI or clomiphene with IUI therapy than the other woman with other primary diagnosis. However, the endometrial thickness is not a significant predictor of pregnancy outcome, and a woman with unexplained infertility and thin endometrial measurement may show improved outcome compared to other women with similar follicular profile where the infertility is because of some other causes. So, one should not be too selective about the endometrial thickness when the decision to move ahead with IUI or not when the oral agents are used for the stimulation in unexplained infertility in IUI cycle. The Cochrane review found no clinical benefit for using clomiphene citrate alone. A recent randomized control trial by Rindoler et al. In 2010 demonstrated the superior efficacy of first line clomiphene citrate and IUI followed by directly to IVF compared with the conventional treatment of CCIUI, FSHIUI in women aged between 21 and 39 years. The pregnancy rates of women receiving the first line IVF were found to be 31% compared to 8% for CCIUI and 10% for gonadotropin IUI. Not only was the IVF more efficacious than conventional treatment, the IVF allowed women to achieve pregnancy 3 months faster. The another set of investigators compared IUI and FSH with expectant management and found similar pregnancy rate in women with unexplained infertility. Their findings and evidence listed above suggest that in women with unexplained fertility, low probability of successful treatment may be avoided by having them undergo IVF directly, although practically this is not feasible, especially in countries like India where it is not supported by the insurance. So, whatever advantage we may get by using oral drugs with IUI or maybe gonadotropin with IUI, which ranges from anywhere between 7 to 12%, we must try. But we have to understand that we have to restrict trial of this treatment, non-IVF treatment, not more than 4 months. After that, patient should be excellent about the success of the IVF and the indication of the IVF in their case. As compared to the younger patient of unexplained infertility, the elderly woman respond better with the gonadotropin. Although the difference is not significant, the gonadotropin therapy is initiated on cycle day 3 with 300 international unit of FSH for 3 days, and the dose was adjusted as indicated by age, ranging between 150 to 300. The pelvic ultrasound and the serum estradiol assessment is done until a lead follicle reaches 17 mm or 2 to 3 follicle more than 15 mm in size were detected. You might use antagonist because this elderly population are more likely to have the premature LS surge. So it is also a good idea to incorporate antagonist into your gonadotropin stimulation protocol for IUI in elderly women. Since the gonadotropin with IUI is not so effective similar to a younger woman, especially in unexplained infertility, older group of patient. It is hypothesized that beginning treatment with immediate IVF would be the most successful strategy so long as there was evidence of a reasonable chance of success before and during the treatment. So, for this, the ovarian reserve testing is required to be done. As we discussed before, the evidence has shown that the use of FSH IUI does not increase the pregnancy rates significantly over CCIUI for younger women. So, gonadotropin with IUI is a definite option in elderly women, not a very good response, not a very good option in younger women. Whenever you are doing IVF for unexplained infertility, we always believe to do ICSI in all cases because we are never sure what might could be the reason for not conception in spite of all parameters apparently normal. It can be a fertilization disorder. So, to cover that fertilization disorder or subtle sperm penetration problem or maybe oocyte problem, the ICSI is always desirable for unexplained infertility IVF cases. The patient having pelvic adhesions, maybe peritubal adhesions, maybe endometriotic adhesions, maybe chocolate cyst, maybe some subserous fibroid, maybe intrauterine adhesion, maybe submucous fibroid, whatever minor problems which are seen during the investigation, and if you treat such causes by fertility promoting endoscopic procedure, once these procedures are over, all these patients should be considered as a unexplained infertility group as far as the treatment strategy is concerned. The prognosis of the treatment, non-IVF treatment, is much better if the patient has got apparently some ovulation disorder or maybe some uterine problem or maybe pelvic adhesion or some other things as compared to unexplained infertility. So I always advise and counsel the patient that if apparently everything looks normal, it is something to be worried, and we should not waste time in just doing controlled ovarian stimulation, time intercourse, IUI for months together, cycles together, but this patient should be quickly shifted to a IVF treatment if couple of cycles of non-IVF treatment is not fruitful. Thank you.